It is 1 minute after the hour, actually 1 p.m. in Hamilton, 1 p.m. in New Jersey, 6 p.m. In the UK, and 7 p.m. in Paris, Torino, Heidelberg, Salamanca. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France, and it is my great pleasure to welcome you all to this post-ASH roundtable dedicated to multiple myeloma, brought to you by the International Academy for Clinical Hematology around the globe and across the hematology field. And this has become a true tradition as part of the ICH educational activities to do these roundtable discussions, sort of so trying to digest what happened in a given disease during the ASH meeting. And this 2023 ASH meeting was quite incredible, very well organized, overcrowded, I must confess, and probably that was the first time in my life that I walked so many feet every day. So I can assure you, I did my 10,000 feet according to my iPhone every day, because it was huge. And we're starting today with myeloma. We'll have other roundtables dedicated to lymphoma, MPNs, etc. And this ASH was always very rich. Myeloma always occupies roughly 25% of the communications, posters, orals, educational sessions at ASH. And myeloma was on the podium. There was a communication, and we'll speak about it. And congratulations, Francesca, who was the lead author during the plenary. There was also a late-breaking abstract, and all of you guys have seen too many studies that we will discuss. It would take us several hours, actually, to go through everything. And to discuss all this, I'm very privileged and honored having, I would say, the usual friends and suspects, and I'll start with the ladies. Dr. Francesca Gay from Italy, Dr. Marivi Mateos from Spain, Dr. Hira Mian from Canada, and I have also Dr. Gordon Cook from the UK, Dr. Facon from Lille in France, and last but not least, Dr. Joshua Richter from New Jersey. So, okay, and I'll try to make it simple, guys. We're not going to make it sophisticated. I'll do it the usual traditional way. We'll start with the transplant eligible patient. We'll move to the non-transplant eligible patient, and then the relapse setting. Just keep it simple and smart. So it looks to me, but you may think differently, that the key highlights in the transplant eligible patient during this last ASH were about two key studies, two major phase 3 randomized trials, namely the Ischia trial, which was presented during the plenary session by Francesca, and this is about comparing KRD to isatuximab KRD. And we had also the later breaking abstract from the EMN presented by Dr. Sonneveld about the Perseus trial comparing DARA VRD to VRD induction, and then we'll discuss the rest of the story. So I'll just stop here and throw my first question, and I don't know who wants to jump in. What are the key messages when it comes to induction based on what you have seen on during ASH and based on these two trials? In another word, is it prime time for quadruplet now for everybody? And if it is the case, is it going to be about first generation proteasome inhibitors or second generation like carfilzomib? Who wants to start? Wow, so I need to designate a volunteer So Hira, you didn't present this, and you usually deal with the elderly and frail patients. So would love to hear your independent opinion.
Sure. So I guess on transplant eligible patients. So I would say, the key message for me from ASH was that probably quadruplets is for induction is really going to be the standard of care going forward. I think a lot of us were interested to look at the follow-up data following Griffin to really have phase 3 randomized data in both Ischia and Perseus, I think, have now moved up a quadruplet induction with an anti-CD38, a PI of your choice, as the induction therapy, I would argue, for both standard risk as well as high risk. I think the maintenance, maybe we'll discuss a little bit more. Is there enough evidence to say that an anti-CD38 and IMiD maintenance should now be the standard of care for everybody? I think it will be interesting to have some follow-up data from additional trials, such as the German trial, the HD7, which has a second randomization. So I think for me, at least, the jury is still a little bit up on the dual maintenance part, but I would say quadruplet induction. Unfortunately, I don't have access to it in Canada, but if I did, I would use it on everybody.
Superb. So, Francesca, you presented the Ischia trial. Can you just remind us the key findings from this trial and where to take it from there?
Yes, sure. So the trial compared, as you mentioned before, KRD induction and consolidation before and after transplant with KRD plus isatuximab. And the follow-up of the trial, the current follow-up is short, is about 20 months. So we are not providing yet any PFS data and any long-term outcome data, but just response and MRD. So what we saw was a significant increase in the rate of MRD negativity in the ISA-KRD arm. This was seen after induction and also after transplant and, of course, after consolidation, with about 67% of patients reaching 10 to minus 6 MRD negativity with ISA-KRD, which is pretty high and is pretty good. And the results that were consistent in all the subgroup of patients, including the high risk and the very high risk, which could be, of course, of importance, considering that these patients are an unmet medical need, of course, with the limitations related to the fact that these are small subgroups. And the second point, that we are looking at the MRD time points and not yet MRD duration, that we know is something we have to look at with the long-term follow-up.
So can I hear, and maybe I'd like to hear from the other colleagues, that you've been maybe too modest, Francesca, because you're saying, oh, the follow-up was short, and maybe we don't have mature data, etc. For me, it's becoming a sort of a schizophrenic situation. Because on one hand, we all advocate that MRD negativity, deep MRD negativity, should be a surrogate marker, because we cannot wait until we get PFS and OS. And here everybody is shy, while we have 2/3 of the patient with a deep 10-6 MRD negativity. Mary V, what do you think? Otherwise we need to be coherent with each other. Either we stop talking about MRD, or we say, oh, we have now the basis for long survival, maybe. I don't know, Mary V.
Yeah, no, I think that both Ischia and Perseus, had been very relevant abstracts presented at ASH. I completely agree, because the quadruplet combinations are being the standard of care for the transplant eligible anti-CD38 monoclonal antibody. And for me, I think that daratumumab or isatuximab are quite equivalent from the efficacy point of view. Lenalidomide, dexamethasone, and maybe the difference is between bortezomib and carfilzomib. We have had some studies comparing bortezomib with carfilzomib. Some studies have been negative, like the Clarion and the Endurance, but the Endeavor study was a positive study in favor of carfilzomib. What Francesca presented, I think that put in context how KRD plus isatuximab, and you pointed out, after consolidation, 78% of the patients or 75% of the patients were in minimal residual disease negative by next generation sequencing, evaluated in a central way. the Perseus study, it's true that maybe we can't compare data, but I think that we can. Maybe we can't take conclusions, and this is something that Rafael Fonseca usually says, but we can do comparisons. And Dara-VRD transplant and Dara-VRD resulted in 58% of MRD negativity rate. So we don't know if ISA-KRD is superior to Dara-VRD, but I think that the quadruplets are the standard of care, and carfilzomib maybe will have an important role in the newly diagnosed myeloma patient transplant eligible. The problem is the ISCA study is not in principle a formal registration study because the control arm was not a standard of care, and this is the main problem. But I completely agree with Francesca. In the population with ultra high risk, in the double hit subgroup of patients, the minimal residual disease negativity rate is excellent. And maybe we are at the right moment in order to put together all data coming from carfilzomib-based combinations in the first line of therapy in order to prove the efficacy, the safety profile, and maybe to convince to the authorities to utilize this combination. I don't know if in all comers, but at least in the patients with high risk or ultra high risk.
So I'm glad you're bringing this into the discussion, Mary V, because we have a couple of questions about this issue of high risk and ultra high risk. And here maybe I would like to ask both Marc and Josh on both sides of the Atlantic, do you believe, and of course I acknowledge that we don't have the proper trial to address this question, but do you believe that the wisdom about saying, okay, carfilzomib is the right drug for the high risk or ultra high risk and willing to use it, or for the time being, you would stick to bortezomib? Josh?
So I think one of the things that we saw, although endurance up front, the main point was that there was no difference in efficacy. When they wrote the trial, 1Q gain was not considered a high-risk lesion. And when they subsetted them out later, there seems to be at least some potential advantage of KRD over VRD. So I do think that there is a role for K in some of these patients. The younger, high-risk or ultra-high-risk, I think there is a potential role. Ultimately, I think you said this wonderfully. Are we ready for quads for all up front? And some of the data from the quads may be so good that we don't even need transplant for some. And I don't want to go down too much that controversial road, but there were two very interesting things as a sequela I just want to throw in quick. One in the Perseus, in the final manuscript, over 65, there was no necessarily benefit. Again, not much of a range there. And in a poster from Jeff Zonder, a follow-up from Griffin, higher BMI in African Americans may not necessarily need transplants. So, as we still classify transplant eligible and ineligible, perhaps data like Francesca presented with the quads is so good, maybe there's some that we don't even need it.
Excellent, thank you. Marc, what is your perspective here?
Yeah, no, I agree. And with a European perspective, of course, we would not routinely be able to use a K-based regimen in frontline transplant eligible patients. We need a strong line of argumentation for the insurance why they should cover that on a case-by-case basis mainly. And I think we have data, at least indirect data, that not only a longer treatment intensity, so to say, based on concept trial, based on indirect evidence now from the ISCA trial, also from Martin Kaiser's Optimum report, that this seems to be beneficial for high-dose, high-risk patients. So not necessarily only carfilzomib, but having a quad that has longer duration with a long consolidation kind of approach. And I mean, even if you look at the Optimum, now the updated Optimum data that were presented at this ASH with a digital comparator, I mean, there in the high risk, ultra high risk patients, although for the rest of the world, an unusual regimen with CRD or KCRD, but we saw that there carfilzomib added a lot. I mean, although not compared, of course, to bortezomib directly. On the other hand, DARA VRD was on a longer run, again, much better in terms of PFS for the ultra-high-risk patients. So I think there's some idea that carfilzomib might do better, as seen in the ISCIA trial for high-risk and ultra-high-risk patients. To me, maybe the most important part, maybe this longer treatment duration of combination therapy, rather than picking one or the other proteasome inhibitor.
But it looks to me that in Germany, at least, you are running the concept trial where you decided in a single arm to use ISA-KRD, correct?
Yeah, sure. That's a phase 2 trial, right? So no comparison. But it has excellent outcome with very good PFS, 2 years PFS and longer now. And so I think it's a very good regimen. The question that I wanted to raise is it far and foremost about K versus V, so to say, or is it more about quad combinations for a longer time? That is, I think, what we might need to figure out as well.
Thierry, I'd like to ask you, so you followed ASH virtually, and this is now a great option when for some reason one cannot travel. And although I know your focus is more on the elderly population, but during the ASH, we had also the press release about the IMROS trial, which tested...
Hazard ratio.
Wait. I don't think he will release it.
You can try.
But according to the press release, 4 drugs did better than 3 drugs. So how do you believe now the outcome? And actually, is it simply like 4 drugs to everybody?
Oh, that's a tricky question anyway. That's a tricky.
Well, you're showing me 2 phase 3 drugs and the young was 4 drugs.
If you put together the ISCIA, the Perseus, and the IMROS press release, you could probably say that 4 drugs will be for younger and elderly patients as well. For the transplant eligible, but you know that if you look at the situation we have in France, that will not change things a lot, because we are already we had DARA VTD approved, and we do every day we do DARA VRD basically. So at least for induction is okay. It is in line with what we are already doing. What will change is likely the maintenance part. So the Perseus study was not there is a DARA arm and there is a no DARA arm, but still, you have bortezomib on daratumumab for, you have lenalidomide on daratumumab for maintenance. So I think that we may switch from lenalidomide single agent to lenalidomide on daratumumab for maintenance. So that may be a change for us. The discussion about KRD, Francesca did a great job, but I said I'm not sure. Technically this is not a study for European approval. Perseus is a study for global approval, I would say. Then you have two strange things, I would say. For the Perseus study, the control arm has not been approved by EMA. So that from a theoretical point of view, that will create something a little bit strange, because the control arm was not approved. But I have no doubt that Perseus will be approved. But that's a kind of approval issue due to EMA some years ago, in fact. For the KRD, we don't have the study results presented by Francesca are impressive for MRD. They are impressive for the high-risk and ultra-high-risk patients. The difference in terms of MRD negativity is huge for the high-risk patients, in fact. Then the next question is, what about some kind of KRD or CD38 KRD approval? So, and that will be for, I don't have the answer, but I think in your country at least, we will not be allowed to use a CD38 KRD, but we will stick to at the present time, we will stick to CD38 VRD on the land on the Raab maintenance. For imos, you just have to wait for a few months. That will be a regular abstract for ASCO, probably. but the study is positive. So you could say that in patients between the age of 65 and 80 years, because patients over the age of 80 years were not enrolled in the imos study, and the frail patients were not enrolled in the Cepheus study in the same way. Okay, there is a superiority of isatuximab VRD over VRD.
Excellent, thank you. So before moving to the maintenance part, Mary-V, you wanted to add something? You raised your hand, or?
Yeah, no, it was just a very brief comment based on the population with high risk, that I think that all these new combinations are quite relevant, and I think Gordon alluded to the optimum trial, that I think that it is very good, but the next step is, in spite of these very effective combinations, more intensive, maybe more prolonged on time, it is necessary to investigate in those patients who relapse. And I think that the optimum trial and Martin Kaiser presented very interesting data in order to try to dissect and to investigate in the characteristics of these patients that they did relapse in spite of these intensive options of therapy, because this will guide us about the possibility of using new mechanism of action also in this high-risk population. So this was just a comment.
Thank you very much. Okay, so now the question is, okay, quadruplet induction debate is there about second generation, first generation protein inhibitor, but definitely anti-CD38 antibodies like isatuximab or daratumumab frontline for maintenance. So here it's a little bit more tricky. Lenalidomide is the approved standard of care, widely used. We've seen data about iberdomide, CELMoD, a sort of a new generation of IMiD, but also in Perseus, actually, those guys in the Dara-VRd arm continue to receive actually Dara-Len, and they receive, so there were no, I would say, double randomization to make a final conclusion. So Gordon, what are your thoughts on this? Because you also presented some data from the UK about maintenance.
Yeah, so the data from the UK was about first relapse, so it's different to what we're talking about. But yeah, I think that's right. And a lot of these studies are taking standard and high risk together and looking at the double agents. And then usually post-trial subgroup analysis is looking at the impact of double agents and high risk. I mean, Francesca's Forte study from presented a couple of years ago showed that KR was better than R for those high-risk patients. So I think it gets complicated because one size doesn't fit all here, and that for some patients that they're going to need at least double agents. But just to circle back to a comment that was raised by Marc in particular, with people with high-risk disease, I don't think it's about double agent maintenance. I think it's more about an acute lymphoblastic leukemia style late intensification, continued exposure for those patients that's going to get them the 2 and 3 year PFSs that we want them to have. And the concept study is looking to prove that as much as the optimum is. So I think taking high risk patients out of the equation brings us back to whether Len, you can uplift on Len by giving dual agent exposure. And I think the data is emerging that does give standard risk patients advantage, but at what cost? And I think that's the thing about maintenance. Maintenance is going to be effective and it's going to be tolerable. And, you know, delivering long-term CD38 brings into exaggerated hypogammaglobulinemia and infections. We're going to be mindful of that. Delivering long-term proteasome inhibitors come with their toxicity. So I think that's what I want to see. I want to see more long-term safety tolerability data in that space. We know these combinations work, but does everybody need it? And what if they then bring in the elements of MRD negativity, and then we start to talk about de-escalation? If you get a really deep MRD negative response, do you need double agents, or do you even need single agents to progression? So I think we've got to actually talk about maintenance in the context of MRD negativity as well.
Okay, thank you, Gordon. So when it comes to maintenance, and now I'm circling back to you, Hira, what is your learning or take-home message from ASH? Did you come back to Hamilton and modified your practice? I'm not talking about approval and reimbursement, but scientifically, do you consider that we have enough evidence today to move from single agent maintenance to double agent, or even, because we have a few questions about this, maybe use MRD negativity as a trigger or to guide this?
So I would say that, for standard risk, I think I still need a little bit more convincing, similar to, like, I want to see that second randomization from the German trial to see whether if you got anti-CD38 induction, does it still matter if you got it in the maintenance setting? So I think from that perspective, I still have a little bit of doubt. It's not changing practice for me at the moment for standard risk. For high risk, I think given the totality of evidence from all the trials, the Forte, concept, optimum, and some of the comments that we've talked about here about that continuous ongoing therapy, I think that dual maintenance is extremely reasonable and should likely be the standard of care. Whether it's going to be a PI IMiD-based maintenance or an anti-CD38 IMiD-based maintenance, again, I think dual maintenance, certainly in that setting, is extremely reasonable. With regards to MRD negativity, I think, again, we'll see emerging data over the next few years from trials that specifically ask this question. Even the Perseus, the stop of maintenance after 24 months in the DR arm was based upon sustained MRD negativity. So we'll see some of the longer term outcomes from that, and specifically clinical trials designed to answer this question of MRD negativity and maintenance duration. So I think for that, we'll just need to see more data.
Okay. Francesca, what are your thoughts?
I completely agree with Hira. I think the point is that we should probably move from a maintenance that is the label with the same approach for every patient to something that is based on the risk and basically also the disease features as well, and the response to treatment. I think that MRD is probably the best tool that we can use to decide to de-escalate maintenance in standard risk. And my personal opinion is that we should try to identify those patients that they have a maintenance but is a fixed duration of long-term treatment rather than a continuous treatment until progression, because it's true that there are toxicities, and it's true that we are seeing now with very long follow-up and long-term survivals, the second primary malignancies that might be an issue. For high risk, it's completely different. I totally agree with the comments that have been made before regarding the need for a combination treatment, prolonged combination. And in this regard, it's important the safety. So not to go back to the K versus Bort story, but the K in the long term, in the end, is manageable, while with bortezomib you often experience the neurological toxicity, which may be a limitation. The other point is that I hope we can stop based on MRD negativity also in high risk. For that, I'm not so sure. We need to see which is the duration of MRD negativity that is needed.
Okay, so Hira and Francesca are in agreement. Is someone in disagreement and believe that we can do doublets? You're smiling, Josh. So maybe in the US you're rich enough to Are you using doublet maintenance in any patient?
For some, yeah, I think I think that the average patient that gets a quadruplet and a transplant, if after all that you still have, and I'm not even talking about MRD positive, you still have real disease, I don't necessarily feel comfortable just putting them, if I give full dose quad and they still have an M-spike of 0.5, I don't feel comfortable lowering the lenalidomide to 10 and just moving forward. That being said, I'm literally sending regular messages to Amrita Krishnan because the SWOG 1803, the dramatic study, I think we're all looking forward to figuring out, yes, there are people that need doublet, there are people that need singlet, but I think as was already brought up by Francesca and Hira, at some point there's some of these people that we can stop.
Marc, what is your take on this?
My take on this is that I really, really hope that the H27 trial will answer a lot of these questions, not about the stopping MRD, because that's not part of it, but because of the second randomization. And we will see, of course, subgroup analysis with high risk, with MRD negativity after transplant, CD38 in induction, no CD38 in induction, but in maintenance and so on. But of course, that's the downside of second randomization. It takes longer to get the data, right? That's why we see Perseus data in this ASH and hopefully the first PFS data of H27 next ASH. But yeah, I only can hope that this will answer and will have enough power at least to give us some idea of subgroup analysis for the subgroups that have been already mentioned, right? But we have to wait at least one more year.
Excellent. So time will tell whether the Perseus results will lead to approval of a doublet maintenance. And I think we had a few comments from the audience highlighting that. And this was between the lines in your answer, Josh, that the biology of the disease may be different and there may be patients who really need a sort of something different, not only lenalidomide, but maybe other options. And actually, we don't speak about it a lot, but for many, many years, in the high-risk cytogenetics, for instance, we were used to say, oh, give them bortezomib every 15 days, and there was a Hovan trial about this. Let me, for the sake of time, I'd like to switch briefly, although there were no breakthrough, but I may be wrong, in the non-transplant eligible patient. And Thierry, any thoughts, something that caught your attention beside the IMROS press release?
Okay, no, I think I was happy to see one part of the Spanish Gemfit study. As you know, the study has 3 arms. One arm is VMP, lenalidomide, and Dex, and the other arm is KRD, and then you have KRD Dara. You have consolidation, etc. But and interestingly, so you don't have patients over the age of 80 years, and because it's a study for fit patients, and you can understand that in order to receive Dara KRD, it's better to be fit if you are an elderly patient. And so okay, I will not provide a lot of comments. So it is a nice study. The PFS is quite good as well. The follow-up is about 30 months, if I remember correctly.
Yeah.
One thing was a little bit not intriguing, I would say, but we found more deaths in the Dara KRD arm, and it was a difference between the Dara KRD and the other arms. It is possibly related to the study population, and okay, I don't know. Mariby will comment, and what is also interesting. I do not know exactly because study populations are always different, but at least if you want to look, IMROS has no patients over the age of 80 years, and the GemFit has no patients over the age of 80 years. If I remember correctly, the GemFit has 1/3 of patients over the age of 75 years.
Yeah.
So these are more or less probably the two study populations are not that different, at least in terms of age. And we may assume that in the IMROS that you don't have so many frail patients. You don't have frail patients by age, but you may anticipate that we will not have a lot of frail patients. So yes, this small signal of more deaths in KRD DARA is a signal, but it means that sometimes if you put 4 drugs together, 4 very active drugs together, you may find more adverse events and potentially more deaths. So this is something we have to keep in mind for the Cepheus, for IMROS, for other studies. So that was my take. Otherwise, the efficacy is good as expected, especially for the KRD and the KRD DARA arms.
Marie-V, would you like to comment, because
Yeah,
Thierry
no, I
alluded to your talk and it was a beautiful one.
Yeah, no, I completely agree. And the trial was focused on fit patients, and definitely the classical combination VMP followed by Lendex was inferior. And concerning, I would say, 3 drug-based combination versus quadruplet, that in this case is KRD, but it is similar to what Cepheus and IMROS are going to compare. For me, I think that the frailty is something critical, because Thierry is right, more deaths occur in DARA KRD. And this is something that we have to improve, because indeed the problem is that the reason for deaths were basically infections in the first 4 months, but the patients infected and patients died. And what we did in a very superficial way, and we will evaluate in more detail in the upcoming months, is to evaluate which patients were at higher risk for infections and death. And this information can be taken from the frailty score. This was a geriatric assessment in hematology that included multiple items, including polypharmacy, mental status, activity, daily living, comorbidities, gait, speed, nutrition. And just we've seen how within the fit population, the more fit those in which the geriatric assessment in hematology score was between 0 and 20, these patients presented an excellent outcome and no toxicity, whilst the patients between 20 and 42 fit as well, but maybe not so fit. These patients, from my point of view, maybe the quadruple combination is not the optimal one. So this is what we are going to evaluate. I repeat, in a very superficial way, we had the opportunity to see how the gait speed as well as the nutritional status influenced a lot in the outcomes, in the prediction, in the capability for predicting toxicity and death. And for me, this is the message. Maybe quadruplet combinations for all elderly patients, not at all. We have to select very well the patients. And another possibility, and I think that there was also another presentation based on dynamic on the frailty. If the nutritional situation is what it is influencing in the frailty of a specific patient, maybe this can be modified and the patient can convert from frail to a, well, not frail, but less fit to a fit patient. So for me, this is the message. And we have to wait, because the trial does include consolidation and maintenance. I think the outcome is going to be quite good, but maybe not for all patients, and we have to select.
Wonderful. Thank you very much. So let's move now to the relapse refractory setting. And actually, we've seen a lot. We had updates about CAR T cells. We heard about CAR-T4 again, KarMMa-3 final analysis. We heard the update about the bispecific elranatamab longer follow-up and PFS now of 17 months, which is quite amazing, I believe. We heard about the use of teclistamab in different disease settings and subgroup of patients. So there was some good news about talquetamab and the possibility to decrease the dosage while improving the safety profile. So here, okay, we will not be able to address all of this because there were also corridors of posters and new agents combinations. Gordon, what is your, in the relapse refractory setting, what is your take-home message from ASH?
I think if you compare this year's presentations with the various assets to last year's, where we say it was all very much, the presentations were driven by the overall response rates, the impressive depth of responses. Now with that time difference, we are starting to see the durability of response. And actually seeing elranatamab's PFS of 17, 18 months is very encouraging because that's what you hope and what you want to see, but we obviously didn't have that information last year. So the durability of response of the T-cell engagers is now maturing nicely and is, I think, delivering on the promise that the overall response rates is delivering. Bear in mind, we've had the durability response for CAR T cells in the relapse refractory setting from previous meetings. So this is us, I guess, the T-cell engagers coming of age, I think I would say, in terms of their that durability response. And with the longer term follow-up, we can actually see the true impact on patient safety, particularly the infective profiles. And I think that is something that's of interest. And we're starting to see real world experience of these agents, which is obviously very different from the very carefully selected patient groups in clinical trials run by industry.
Okay, thank you, Gordon. Josh, what's your current practice today? Bispecific, CAR T cells, and then I would like to dig a little bit deeper into some of the results.
Sure. Well, you know, I love Gordon's take on this year versus last year. I would say, and yes, there was amazing data on BCMA, but I want to say this year was a GPRC5D cavalcade. The wonderful follow-up on talquetamab, and as well as Susan Ball presenting the GPRC5D CAR T. So, you know, I think one of the things that we're seeing a lot of is we're lucky enough in the US to have 3 FDA-approved bispecifics, 2 BCMA, 1 GPRC5D, 2 FDA-approved CAR T cells. When we're trying to get to CAR T, we love to give patients those disease-free intervals, but they show up when they're relapsed, they're not always have the disease kinetic to wait for a CAR T. So we have had a lot more earlier utilization of talquetamab to try to preserve BCMA for a CAR T later on. So I think that looking for new uses of talquetamab and including Jeff Mattis's combinations with pomalidomide, the GPRC5D world is here to stay.
Yeah, but I think, Josh, you have missed the rule at ASH because we go by alphabetical order. Last year, it was BCMA because it was B. And this year, we go to the G. So that was the trick.
That's
you missed it. Yeah, absolutely. So CAR T cells, Marie V. We had a beautiful final analysis about KarMMa-3. And for me, when I looked to the slides, it was a little bit difficult to do, to have the right interpretation. So can you give us a summary about these?
It's nicely said. It's nicely said.
Nicely said.
No. I'm just playing, my role of a sort of a devil advocate there.
No, Mohamad, I think that, well, the final data from the KarMMa-3 were presented. And for me, this is a phase 3 clinical study in which ide-cel showed to be superior to different standard of cares in a population of relapsed refractory myeloma after 2 to 4 prior lines of therapy. But I would like to remark that almost 70% of the patients were triple class refractory. And for me, this is the key question. when one patient become a triple class refractory, there is an unmet medical need. And this is the reason why, in terms of progression-free survival, the different standard of care resulted in a median PFS of 4.4 months, and IDCL resulted in 13.8 months. The trial was positive. What the final analysis showed was the overall survival. And on the intent to treat patient population, there was not a significant benefit for IDCL in comparison with the different standard of cares. 41 months versus 38 months with a hazard ratio of 1.01. But the problem, and for me, I think that this is the explanation, that crossover was allowed, and this means that almost 50% of the patients, a bit less than 50% of the patients who were allocated to the control arm received IDCL at the moment of relapse. And this is, from my point of view, the reason why there was not a significant benefit in overall survival. They presented a sensitive analysis adjusted for crossover, so eliminating this impact, and it was possible to see how there was a benefit in overall survival for IDCL over the standard of care. And if I remember well, the hazard ratio was 0.7. So for me, I don't know if this is a very simple explanation of the complex presentation, but for me, crossover was allowed. I think that this was very positive for the patients included in the KarMMa-3, and this is the reason why patients didn't result or didn't get a benefit in overall survival. But the patients in the crossover had the opportunity for receiving IDCL, and maybe they had a benefit in terms of progression-free survival when they receive IDCL.
I think it's a very reasonable explanation, and please don't misunderstand me. I'm very positive about this trial and the other trials. So Francesca, assuming patient received a patient in your trial, cetuximab KRD, len maintenance, and then at time of relapse, you have the different available options now. What would be your approach based on the ASH data?
Well, I think that it makes always sense to try after relapse to expose the patient to something that acts against a different targets and with a different mechanism of action. So even if potentially patients relapsing maybe after a long time of exposure from anti-CD38 and PI can be re-exposed effectively to these agents, I would be tempted anyway, if available, to go for an anti-BCMA agent, for instance. I think these will be the ones that might be available soon, because in my country still we don't have them. And preferentially, to be honest, I think CAR T cells have a very good option because these are a one-shot therapy. Of course, if the patient can wait the CAR T, and if you have an effective bridging therapy that you can use, which could be the case if we move CAR T cells early on, if we compare to the use in later lines where the effective bridging therapy are less because the disease is exposed and is refractory to many agents. In case the patient cannot do this because you don't have the slot, because the patient can't wait and so on, I think the bispecific are, of course, a good option. And I think Joshua touched a good point. If you have anti-BCMA CAR T available, but you might not be able to use it immediately, and you have a bispecifics against another target, well, you may choose to go for against another target, the GPRC5D, and then maybe leave the anti-BCMA treatment with CAR T later on, even if we know that this is probably not the best sequence of different T-cell directed therapy, which is probably the opposite.
Okay, thank you very much. Marc, do you share the same approach, and how do you use these new immunotherapies? Because I guess in Germany you have access to IDCL, you have access to cilta-cel, And you have access to bispecifics. Germany is a rich place.
Well, we pretend to be, yeah. Actually, we have, yeah.
And I love my German friends, by the way. There was no negative or bad feeling.
We have access, you're right. I mean, in the regular label so far, so of course not in second line or third line according to CARTITUDE 2, 4 or KarMMa 3. Yeah, we try to, of course, switch targets, switch classes, and so on as much as possible. We started using talquetamab for bridging therapy, actually, because our biggest challenge for CAR-Ts in the current label is that almost all patients had whatever is standard of care before, so there is hardly any effective bridging therapy left. So, and if you have, for example, a bispecific available, even if you just give it for 2 cycles as a bridging therapy after apheresis, it's sometimes the only way to stabilize or even get the disease in response. And I think we all know that CAR-Ts work much better in a controlled disease rather than in a highly dynamic disease. So that's what we just started in as a real world practice in quite some centers so far, with good but short-term follow-up results, of course. Talking about the 2 studies, the 2 phase 3 CAR T-cell studies and their updates, I mean, what I wanted to add as a takeaway or as an observation, let's put it this way, both in KarMMa 3 and CARTITUDE 4, we see in the CAR arms these early dropouts, even before CAR T-cell infusion, that are disbalanced compared to the control arms, which to me raises the question, how do we best select patients who we actually plan for CAR-Ts? Because that, to me at least, leads to the conclusion that the therapy leading to apheresis and then the bridging therapy seems to be suboptimal for some patients, because otherwise it wouldn't explain why there's more dropout in the CAR T-cell arm before CAR T-cell infusion compared to the control arm. So I think we, based also on real-world data, we have to learn quite a lot how to get those patients, how to pre-select those patients, and then how to get those patients best to the CAR T-cell, actually CAR T-cell therapy, which still takes quite a while until you get the product back and you are able to infuse it. And one of these approaches, as I said, now would be to use a bispecific after apheresis, so you at least hopefully do not hamper or influence the product itself.
Excellent, thank you very much. So we've seen regarding the bispecific, I was quite impressed with almost every patient can receive a bispecific, including patient with kidney failure, under dialysis. So here my question to Thierry and Hira regarding the elderly, most frail patient. How do you see the role of bispecific there? And for instance, because Josh mentioned that GPRC5D was a keyword at ASH, given the possible or potential side effects and how to minimize them, because they can alter the quality of life of the patient, dysgeusia, and loss of appetite, etc. Thierry, what's your take on this?
Oh, that's a big question. I think, you know, okay, to be honest, I think some of...
You always need to be honest, Thierry.
I'm always honest. Anyway, I think I am a little bit concerned about some ongoing studies with bispecific in older patients in frontline, especially those studies combining a bispecific, the LEN on the DARA, because going back to what was observed in the Gemfit study, for example, when you put 4 drugs together, whatever the drug, and if you pick the patient with some degree of frailty, you don't know exactly, but you may create adverse events. And I think if you put this in the context of some kind of continuous therapy, you may create toxicity. And so I still believe that we give too much bispecific for the elderly, especially for the frail. I think schedules will have to change. dosing schedules will be different. So they just forget the weekly, even forget the every 2 weeks. So that will be maybe at the beginning every 2 weeks, then every 4 weeks, and maybe every 8 weeks. I don't know, but that the schedules will need to change. I hope there is a role for bispecific in a frontline setting for the non-fit or the somewhat frail patients, maybe for the frail patient, but we still have a lot of work to do in order to achieve this. Then your question about the GPRC5D, one thing I had in mind looking at presentations, I looked at this CAR-T GPRC5D, and I looked at the talquetamab, some talquetamab study. So one with POM, one is a de-escalation study with talquetamab. And the conclusion of the CAR-T study was said basically that if you want to target GPRC5D, theoretically a CAR-T could be better because the toxicity is as a limited duration. Basically, you get skin toxicity, dysgeusia for some days or some weeks, but you don't have to face these toxicities for 1 year or 2 years. So I think it's possibly a good point. You may claim that if you want to target GPRC5D, a CAR-T might be better, or if you want to stick with a bispecific, you have to. I think we probably need to further reduce the talquetamab dosing or the talquetamab schedule. But I hope, I strongly hope there is a role for bispecific in the frail. Otherwise, you could say that we will not stay forever with DRD or CD38 VRD or whatever. We have to improve on it, of course.
So, Hira, what did you think about this issue of adjusting the dosing, especially that there was this oral communication by Dr. Mateos and colleagues combining talquetamab and pomalidomide? And when I looked into the presentation, the median age actually was 69 in the 0.4 milligram per kg group plus POM, and it went up to 78, age 78. So it looks like not only if we lower the dose, we can give it, but we can even combine it with an IMiD.
So again, I mean, I think Professor Facon has raised all the important points. It will come down to not the age, the frailty of the patient. So even when we look at that age group, it will come down to how frail were they. And, Gordon had some fantastic abstracts, even on this ultra frail population, those with a score of 3 or higher. And I think those are the populations we're going to really struggle with, where we're going to have to really come up with great frailty measures. And then I think, data from, again, Gordon's group and Sonia's group around this dynamic frailty that Mary V touched on as well, is that maybe we start off with single agent. I'm just predicting the future, single agent bispecific. Frailty improves or deteriorates, then we add in that POM or whatever else. So I think we're going to, hopefully, now that we have these agents, we're going to learn how to use them. And that's why it was great to see a lot of real world data, but we have a lot more to learn. And I'm quite hopeful that we will be able to use a lot of these agents in older adults, including among frail older adults, but it will come down to how to really incorporate frailty into the initial risk stratification, and then also dynamic frailty into subsequent risk stratifications as well.
Thank you.
I just have a short comment on this. I looked at the study reported by Irene Gabriel, the PRISM study in high-risk smoldering with
teclistamab.
With teclistamab, that's a very small cohort of patients. But that being said, she got 100% response, and all of these patients were MRD negative patients. So you could say it's a little bit too much, it's too optimistic, whatever. But even as a single agent, in some patients, these drugs are extremely effective. You could claim that they are too effective. You just have to learn how to use these drugs, in fact, and to keep to keep it safe, you know. So, and this is true for all patients, but this is especially true for the elderly and the frail patients.
No,
just to add,
please.
sorry, just to add to what Thierry, I'm glad Thierry raised the immunoprism study, because yes, it was a small study, as Thierry says, and we saw fairly dramatic effects of single agent teclistamab. But I guess the point that Irene was trying to make is that the immune system in smoldering is perhaps more effectively managed by bispecifics than it is when you get to myeloma and even further down the line relapse refractory. Yeah. And as Thierry says, you might be able to get the same bang for your buck by even turning down the exposure because of that. And I thought, I mean, the other thing that surprised me about that is the lack of, at least in the presentation anyway, the lack of infective toxicities. I fully expect there to be absolute carnage in this population, but there wasn't. So again, maybe a fertile ground to expose to, you know, immunotherapies. I thought it was a very interesting article.
Thank you. So we spoke about our ability, and I think this is really good news, to minimize the side effects of talquetamab. In the last couple of years, we have put a lot of emphasis on opportunistic infections after bispecifics. And it looks like to me that during this ASH meeting, things have calmed down. Either infectious complications have simply disappeared, or maybe people were following more the guidelines and there is a learning curve, and by applying the right prophylactic measures, the screening for microbial organism, but also substitution with immunoglobulins have, I would say, allowed us to control the situation. What's your take, Marie-V, on this?
I think that you are maybe too optimistic.
I'm always
I would
optimistic.
say that I think that the work is being done, and maybe I want also to be optimistic, and maybe we will see positive results in the upcoming years. I think that everybody now is improving definitely the optimization of the use of bispecific monoclonal antibodies overall in order to decrease the infection rate. And we do the adequate prophylaxis, antiviral, anti-PGP, antibacterial in selected patients, the vaccinations, and the support with IV immunoglobulins in case of hypogammaglobulinemia. And I think that there is another important information. We are also introducing less frequent dosing. Now it is maybe allowed for some bispecific monoclonal antibodies, but I think physicians outside of clinical trials are being even more flexible in this less frequent dosing, and physicians are moving or switching to the every other week administration or to the every month administration earlier than expected. And I think that this can potentially impact in the infection rate. But we can't forget that, for example, the French group reported their experience in the real life with the different bispecific monoclonal antibodies. And in spite of the adequate prophylaxis, the infection rate was quite high. And another important information from the management point of view, I think some physicians are utilizing dexamethasone in order to mitigate CRS in terms of instead of tocilizumab. And if I remember well, in the presentation from the French group, dexamethasone emerged as an important variable, also increasing the risk of infection. So I think that we have to take care. We have to we have to use the adequate prophylaxis, maybe less frequent dosing, immunoglobulins, but take care with other situations. And one example is the use of dexamethasone, because they can potentially increase. But I think that the work is in progress, and we will see. I wanted to consider less infections in the future.
Wonderful. Thank you very much, Marie-V. And I think all of us are optimistic. So for the last 9 minutes, because we've scheduled 75-minute webinar. I would like to ask each of you about your final thoughts and maybe what you would love to do or to see in the next 12 months while waiting for the next ASH in San Diego, same place. So, and I do recommend that you book your flights earlier, then you got cheaper flights. Francesca, because we were debating about the cost of flights, expensive cost of flights. Francesca.
So what I would like to see in the next 12 months, looking for the next ASH, I hope we can provide some more guidance in clinical practice for the first line. And I think it would be nice to have the data from the German study that Marc was mentioning regarding the maintenance phase and the use of the anti-CD38 monoclonal antibody in maintenance. I hope we will also be able to look at some strategic question. What is the best approach? MRD yes, MRD no, but maybe not in the next 12 months. And the other point, I think we discuss a lot about the safety in the elderly and the safety in the frail and the use of bispecific, how to optimize the toxicity. I think these are great drugs that work very well with high rate of response. So if we can implement them in clinical practice, improving as much as possible the safety side, it would be really great. And for that, I'm really optimistic.
Wonderful. Thank you, Josh.
Yeah, so one of the things that we have been doing recently, and this data was previously presented by Mary V, the redirect study, combining both teclistamab and talquetamab, and we're seeing some profound responses in patients, particularly with extramedullary disease. That being said, you know, I love a lot of the data out there looking into fixed duration or target duration with these drugs, because I don't know that, just like maintenance, I don't know we need to keep people on them forever. So work that's being done with cevostamab with fixed duration, and a wonderful IIT from Al Garfal at UPenn, his Limitex study, looking to achieve deep responses and stopping. So hoping to see more data of combinations, but limited duration bispecifics.
Excellent. Hira.
So I guess for me, the big things I'm looking forward to, again, results from the German trial about this role of anti-CD38 IMiD maintenance to help us really kind of finalize our answer on that. Also really interested to see the results of the Midas trial in the upcoming year or so, because Josh kind of touched, we didn't quite touch on it, but this role of transplantation, especially when you have a quadruplet, and, you know, the Midas trial will maybe help us answer that a little bit. So I hopefully that will read out next ASH as well. And then from a clinical trial perspective, I would say, you know, this was kind of a big year for dynamic frailty and the importance of it. So would love to see more clinical trial designs that actually incorporate that in their endpoints or in their stratification. So it would be great to see some novel trial designs around that.
Superb. Thank you. Gordon.
Yep, just picking up on where Hira left off there. I think over the next year, I'd like to see a bit more detail about how we evolve, how we classify older, frail patients. We've done a lot so far, but there's still a lot to go, and look forward to seeing that. I guess in hopefully in 2024, the end of, we might see some durability of response data from Salman Mani's IFM 2017-03 study. I think that looks really good. It's a steroid-free arm in particular that looks the most attractive. And also I'd quite like to see a bit more of event-free survival analyses in the elderly studies rather than PFS, because I think that's probably more meaningful for that population. We've still got a lot of work to do for the older population with myeloma, and I'm looking forward to seeing more work. And as Hira said, you know, maybe some more trial in progress showing new trial designs in that group of patients by the end of next year.
Excellent. Thank you very much. So, Marc, beside waiting for your own trial results, what you would like to see?
Just was saying, I'm not going to repeat that one. No, honestly, I'm not sure whether we can expect something like that at next ASH already, but what I'm really interested to see how to see any data or any ideas or hints how we might be able to use MRD to trigger treatment decisions, not only as an endpoint in a trial, but whether if I have to force a patient into MRD negativity, or if it is just by the planned treatment, MRD negativity is the prognostic factor, or is it the goal, so that I need to switch therapy if I'm not reaching MRD negativity. And similar and along those lines, whether if I lose MRD negativity on the run or in a maintenance setting, whether I need to reintroduce the same or a different regimen early on. I mean, there are trials addressing these questions. I hope that we will get at least early data soon, so that we step by step can learn on how to use MRD not only as an endpoint for trials, but also in real life, at least in some patients, mainly, of course, thinking about high-risk patients first, but also then into thinking about stopping treatment, of course, for standard risk patients like sustained MRD negativity and so on.
Thank you, Marc. Thierry?
Many things have been said. Just one comment, I think that by the end of next year, the 4-drug combination regimens will be very stabilized, in fact, because you will. So nobody is interested in imos. But you will have the follow-up of the Perseus. You will have the German study. You may have Midas study results. You will have 4 drugs in elderly. We will be on the way. Some of these regimens will be approved by EMA, by other regulatory people. So this is something important, which means that by the end of 2024 or early 2025, at the time of diagnosis, many patients will receive a CD38 in combination with either VRD or KRD, and that will be done. So the first line will be defined in a way. So it's something important for patients. It means that then, in terms of sequencing, what we said about, for example, you may receive a CD38 VRD or KRD first line. You may then receive, you will get a long PFS. Then at the time of the first relapse, you may get BCMA. You will have a lot of possibilities for bridging therapy. So the treatment paradigm will change, and the first line of therapy will be defined for some years at least. So I think that will be an achievement. Then you have a lot of questions about MRD, a lot of questions about the way to. I think the bispecific management is something important in terms of real life, and okay, this is what is important from my point of view.
Thank you, Thierry. Very lots of words of wisdom. Last but not least, Marie-V.
Yeah, so I would say that we will see more and more data about the risk and response adaptive therapy in myeloma. And I think that this is what we are seeing more and more at the different ASH meetings. And I think that this is the optimal way in order to manage our patients with myeloma. We will clarify maintenance. I would say that maybe we will start to have some data about bispecific monoclonal antibodies in earlier lines of therapy after just 1 to 3 prior lines of therapy, more mature data about CAR-T in earlier lines of therapy, maybe new CAR-Ts beyond the BCMA. This year we've seen GPRC5D, but maybe dual CAR-Ts are coming. So definitely many news. And last but not least, we have to rescue once more again belantamab mafodotin, because until now it was basically disappeared, but we know that positive data are coming, so maybe we have to incorporate belamaf-based combination into the treatment landscape in order to select for whom this combination will be the optimal choice.
Thank you very much, Marie-V. And of course, we never deliberately avoid speaking about this or this drug, and you're alluding to the DREAM7 positive trial, and I do congratulate the investigator for this. There are also many great other agents. I think we didn't speak about mezigdomide. We didn't speak about iberdomide. We didn't speak about trispecific antibodies. But this is why actually we need you frequently here at the IACH, guys. And you have to follow the activities, and probably will have, I think, given the amount of data we had at ASH, we'll probably organize something during January, but we're working on it with the steering committee. So I hope everybody has enjoyed this discussion. I'd like to thank the panelists for sharing their thoughts, their wisdom, their advice, but also their knowledge with all of us. And I'd like to thank the attendees, especially those who took the time to ask questions and send comments. I do apologize, we were not able to address all questions. Also, I did my best to type some answers if you check your message boxes. So time to say thank you, and wherever you are, whoever you meet, wherever you go, please stay safe and keep well. See you soon, and happy end of the year holidays. Merry Christmas.
Thank you. Bye.